Hi, and welcome to your Nursing 182 lecture on intrapartum nursing care. In this lecture, we're going to go over essentially what happens in the labor and delivery room and in the labor and delivery world. So let's get started. So today we're going to talk about the 5 Ps, the process of and adaptations to labor, pain management, fetal assessment, nursing care, and then there will be a second lecture that goes over various complications such as preterm labor, premature rupture of membranes, dystocias, various procedures, medications, and emergencies. So what are we talking about when we talk about the 5 Ps? And what does the 5 Ps refer to overall? The 5 Ps are what we're assessing to determine whether the baby's going to come out, essentially. So we're looking at the passenger, the passageway, the powers, the maternal position, and the psych response, and that's of the mom. So we're going to discuss each of these a little bit more in depth. So when we talk about the passenger, we're talking about the baby. So the baby is our passenger. So what do we need to consider when we're discussing the baby? First, we're going to want to talk about the baby's head because that's going to be the presenting part in 99.9% of vaginal births. And then we're going to talk about the fetal presentation, the fetal lie, the fetal attitude, and the placenta. So when we look at the head, we have what are called suture lines, and we have our fontanelles. What happens with the sutures is that they haven't fused yet so that the head can form and mold to the size of the mom's pelvis. So if we have a baby's head whose sutures have fused, then that baby's not going to be able to fit through the pelvis. That's a very rare occurrence, but it is something to consider. So when we're looking at the bones, and for those of you who have had the opportunity to do a newborn assessment, when you're feeling those bones, they feel like separate bones. They are also oftentimes overlapping. And this is to, again, allow for the head to mold to make it out of the pelvis. And then in addition, it allows for the brain to grow. So when we're looking at the presentation, we're talking about how the baby is positioned in the abdomen and in relation to the pelvis. Now, you can see down here the ROA. So this baby is the occiput. We're referring to the occiput. So ROA is right occiput anterior. So the occiput of the baby is on mom's right side. LOA is left occiput anterior. So the baby's occiput is on the left side. Now, if you've ever tried to put on a tight turtleneck, you don't put it on over your face. You pull it on over the back of your head. This is also good advice for parents of small children and newborns because oftentimes their necks are much smaller than their heads, so the shirt opening doesn't always want to fit over the head. So if you pull it over the occiput of the head, this is the smallest point, it will stretch much nicer. And this is the same concept with birth. If we have the smallest point of the head leading the way, the rest will follow so much easier. So you can see here with our ROP and LOP, not only is the baby itself facing. So you can see here the back is towards mom's front. So we have some space here where the arms, the legs, and the limbs are. Here we have the baby's back kind of towards mom's spine. So with our OP positions, which is occiput posterior, in which case the occiput is not going to be the presenting part of the head. Instead, we're going to have the frontal area as the presenting part. In these OP babies, occiput posterior, mom is going to experience significant pain in her back. We refer to that as back labor. And that is, again, because the majority of the baby is facing up against her back. So that's where a lot of the pushing and pulling is occurring. And when that happens, not only does mom experience that back labor, but she also is going to have a really tough time pushing that kiddo out, because instead of the small part, the occiput being anterior and leading the way out, the occiput is posterior, and the frontal part of the head is leading the way out, which is a much larger diameter. So it's much harder to push the baby out. With these transverse lies, the baby is going to end up turning one way or another, and we really hope that they turn to be occiput anterior. So you can see here some of the information. So the lie has to do with the longitudinal or vertical direction. The presentation, here these are all vertex presentation. So the lie is either posterior or anterior. And then the presentation is going to be vertex, which means head down. The reference point, we're always talking about the occiput because that's what we want to come out first. And the attitude of the baby is not like your teenage daughter's attitude, but it has to do with the remaining positioning of the fetal body is what we're talking about when we speak about attitude, and we want complete flexion. So here are some other positions. We have frank breech, which could potentially be delivered vaginally. Most of the time it will not be, but it could potentially be. So here we have their longitudinal or vertical. The presentation, though, here is breech. The presenting part is the sacrum, and the attitude is flexion, except the knees, the legs at the knees are extended. Otherwise, the baby is flexed. For a single footling breech, this would not be attempted vaginally on purpose. Babies are born this way in ambulances or on the side of the freeway sometimes, but this would not be something that we would purposefully deliver vaginally. You can see that there's a foot hanging out there, and there's flexion except for the one leg that is extended at the hip and the knee. And then we have a complete breech, and this is the other one that could potentially be delivered vaginally. And we have both the sacrum and the feet as the presenting part, and we have general flexion for this kiddo. Now, a transverse or horizontal baby is always going to be delivered via C-section. There's no way for this baby to, there's no way for a baby in a transverse position to be delivered vaginally. So think about that. In 300 years ago, 400 years ago, before C-sections were commonplace, how were these kiddos delivered? What did we do? This kind of explains why we had such a high maternal and fetal death rate associated with birth. So we didn't have a good way to get these kids out. Sometimes the practitioner would try to turn them, but that didn't always work. So another aspect is going to be with the positioning of the baby has to do with the station. So when we talk about the station, we're talking about the head as it relates to the ischial spine. So the ischial spines are 0. And so when we're feeling for the station of the baby, we're going to be feeling for those ischial spines and on the mother to determine where our 0 station is. And then we assess where we go from there. So if the baby is above the ischial spines, then their station is going to be in the negative. If they are below the ischial spines, then the station is going to be positive. And station is always important for when we start pushing with a patient. Typically speaking, first-time moms, we want that kiddo to be at least a +2 before we start pushing. Moms who've had kids before, honestly, it doesn't really matter. They're going to probably be pretty good pushers if they've had a vaginal birth before. So if they're complete and feeling an urge to push, then we're going to allow them to do that. If they are not feeling that urge to push, then we would wait. But we want that kiddo to come on down and get to, usually think about it as +2 is a good place to start pushing. So the next thing we're looking at is the powers. So when we're looking at powers, we're talking about contractions, and contractions create cervical dilation. So here's an picture in your OB survival skills lecture. That I think I had the same picture with another good indication of what cervical dilation looks like. And so here we discuss that the cervix needs to be completely gone before we can start pushing and have a baby. So what we do is we're going to check mom. And what we want is we want our powers, which is our contractions, to be strong enough to pull that cervix all the way away and to thin it out and make it go completely away. So as I have said before, although we call somebody 10 centimeters, what we're really looking for is the absence of cervix. So that means that the cervix has been completely pulled away from the lower uterine segment and is no longer there. And that is when we're able to start pushing. So we need to have contractions that are strong enough to do that. So here we're looking at a baby's head as it's coming down. So we have, this is our cervix here. We have the internal os and the external os. And as the powers increase, the cervix begins to thin out and open up. So here you can see I have a much thinner cervix. This is going to be the vaginal vault here. This is a much thinner cervix that has started to open up a little bit. You can see that the internal os is all the way up here now. So the cervix is really pulling up into that lower uterine segment. You've seen this slide before as well. Some of this lecture is a little bit of a repeat from survival skills, since survival skills focuses on labor and delivery, but it's good to hear it again. So here we're looking at a fetal heart rate here and contractions here. And we have, here we're looking at contractions from a intrauterine pressure catheter, which is the internal monitor. And here is a tocotransducer, which is the external monitor. And here we're looking at the internal monitor, which is the electrode, the fetal scalp electrode or spiral electrode. And here's the external monitor, which is the ultrasound that goes on mom's tummy. Remember, uterine contractions measured by an external monitor cannot give us intensity. We have to touch our mom's tummy to determine how intense they are. Just because our contraction goes up to 100 does not mean that it is any stronger than one that only goes to 70. If it's a external monitor. So we cannot determine strength of contractions with external monitors. What we can look at, though, is the duration and the pattern. So what we do is we count from the beginning of one contraction to the beginning of the next. And that is how long that contraction is lasting. So here, our contraction starts about here. So we're going to count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So these contractions are 110 seconds apart, and the contraction is lasting 1, 2, 3, 4, 5, so about 50 seconds. So we measure how far apart they are from the beginning of one to the beginning of the next. And we measure the duration from the start of one contraction to the end. And we would document that as a range. So we would find the longest contraction of the 30-minute period and the shortest. And we would document, for instance, contractions 40 seconds to 90 seconds. My shortest one was 40 seconds and my longest one was 90 seconds. And if my duration or my frequency was between 2 and 4 minutes, then I would document from 2 to 4 minutes between contractions. Now, for the uterus to adequately provide oxygenation to the placenta and the placenta to adequately provide blood flow to the baby, there needs to be at least a 60-second resting tone in between contractions. So we ideally want contractions that are less than 100 seconds long with a 60-second resting tone in between to promote adequate fetal oxygenation. So again, that was ideally about 100 seconds, no longer than 100 seconds long, the duration, and a frequency that allows for a 60-second rest period in between contractions. So what is Ferguson's reflex? Ferguson's reflex essentially is the urge to push. What's happening here is that the head is pushing down on the cervix and on the rectum, which is going to provide feedback to the pituitary, which is going to provide more oxytocin, which is going to provide stronger, more frequent contractions, and is going to push the baby down further. So as the baby descends and provides more pressure on the cervix and the rectum, then theoretically we're going to have stronger, more frequent contractions. And that is what we see. And we want those really strong contractions so that mom can pair up with those when she's pushing, and that between the contraction and mom's effort, we're going to deliver a baby. So this all has to do with the powers. And now we're going to move on to position. So maternal position is going to impact how quickly labor progresses and how quickly she delivers the baby. Not to say that one position is better than another position. However, the movement and change in positions is key. We want to be moving our moms a minimum of every 2 hours during latent labor, every 1 hour during active labor, and at least every 30 minutes during the second stage of labor, which is pushing. The different movements are going to allow the baby to move into the optimum position. So as we move mom, we're giving the fetus an opportunity to move as well. So you can see here we have lithotomy, semi-recumbent, lateral recumbent, and squatting. Not everybody is going to be able to utilize the squatting position because of epidural anesthesia, or analgesia, which is going to cause the legs to be numb. But you can see here this bar that we have. And we have a squat bar for every bed. And we're able to even help those epiduralized moms to get into something that simulates a squatting position with the use of the bar and some towels and sheets and a variety of different things. One tool that we utilize in labor to help with positioning, especially if the mom has an epidural, is called a peanut ball. And the peanut ball is shaped like a peanut, but it looks like one of those exercise balls, or it's the material of an exercise ball. And what the peanut ball does is it helps to keep mom's hips nice and open so that during labor, that baby's able to come on down. So we're going to have mom positioned on her side with a peanut ball in between her legs to open up her pelvis. And then we're going to be moving her to the other side every hour or so, just to make sure that that baby is able to move on down. So this is just an interesting cultural fact that in the Philippines, there's a group called the Luzon who believe that if the expectant mother quarrels with her own mother or her mother-in-law, she will have a difficult delivery. So what impact do you think that that has on the maternal psyche? And that's what we're going to talk about next. So here we have a picture of elephants. Why do we have a picture of elephants? Because elephants are fabulous at supporting one another in birth and supporting the maternal psyche. So there's this fabulous story about an elephant who was at a zoo who was about to give birth. And so the zookeepers thought they would do this elephant some good and separate her from the other elephants. And this particular zoo hadn't experienced an elephant birth before. So they separated mom, and her labor went on and on and on, and she was struggling and having a really tough labor, and they could see that. The zookeepers could tell that she was really struggling. And the other elephants, the other girl elephants, were watching her, and they were standing by the fence, and they were up in arms, if you will. They were making a lot of noise, stomping their feet. They looked like they wanted to break the fence down. So the zookeepers thought, well, let's let them in and see what happens. And as soon as they let those other women elephants in, they surrounded the mom-to-be, and within minutes, she gave birth. And when they surrounded her, they started stroking her with their trunks and rubbing their heads up against her. They were providing her with labor support. How cool is that? And I know that I've mentioned in class before that there's a famous research study that shows that just the presence of another woman in the labor room without her even speaking to the mom increases the positive outcomes of the birth and shortens the duration of the labor. It's kind of fascinating. So we're somewhat similar to elephants in that we want to be supported in our labor. We're always going to want to support the maternal desires. So if mom does not want her mother-in-law in the room, we're going to help her with that to get the mother-in-law out of the room. Sometimes this ends up involving security, unfortunately. However, we're going to provide a safe, calm environment for our birthing mom, because she is our priority. That mom and that baby are our patients. Everybody else is a visitor, and we need to keep that in mind. We're also going to provide her the support that she needs. So if our mom is waiting for her epidural, let's say, and is in excruciating pain from her labor, we are not going to walk out and go socialize with our nurses in the nursing station. We're going to stay with her side by side until we can get her comfortable, because we need to provide her that support. Stepping out to retrieve medication or supplies is acceptable if you're gone for a short period of time. And sometimes we might want to call another nurse in to have them go get those supplies for us, as opposed to leaving our laboring mom. We're also similar to animals in that animals will not birth a baby under duress. So if you think about fight or flight and our various nervous systems, the uterus is not part of our sympathetic, it's part of our parasympathetic our parasympathetic nervous system. The uterus is part of the parasympathetic nervous system because the uterus is not going to be active in moments of stress and times of stress. So animals a lot of the time will hold on if there's some sort of a natural disaster. We notice an influx of baby animals after that. And that's because they weren't going to birth their baby under the duress of the natural disaster. Humans are the same way. If mom is stressed out because of the visitors in her room or other external factors, we need to help her eliminate those. The other thing we want to think about is how we're helping our moms to cope. Some women are going to cope by screaming their heads off. And if they're coping, which means that in between contractions, they're actually able to talk to you, then that's okay. They can scream all they want. If they are not coping, then we're going to want to help them cope by redirecting them. So we can ask them to look at us. We can direct their breathing. We can get them to change position. Have them open their eyes if their eyes are screwed shut, which sometimes women do. So all of those things will help to redirect a woman, but we only want to use them if she's not coping. If she's coping, we're just going to let her cope however she copes best. So we have talked about the 5 Ps, and now we're going to talk about the actual process of labor. So what happens if all of our 5 Ps line up and we have a really great passenger whose head is not too big? And if the head is too big, it's something called cephalopelvic disproportion, and it does happen, but not too frequently. So if we have our passenger, which isn't too big, we have our passageway, which means that mom's pelvis is a good size and shape, and that the baby is in a good position to pass through. We have strong enough powers or contractions. The maternal position has allowed for the baby to get into position itself, and we have a mom in a good psychological state. We are going to start to have the process of labor and of birth. So first, the baby's going to engage into the pelvis, and then it's going to start to descend. As it descends, we're going to see flexion, internal rotation, extension, external rotation, also referred to as restitution, and expulsion. And I will show you this with a kiddo in class, because it's hard to visualize even with the pictures in the book. So we'll go over this in class. Some things that we're going to look for with our baby is our baby's heart rate. So what are some things that are happening with our heart rate? We're going to see that the baby is most likely having early decelerations where the head is being compressed. And so we're seeing a little bit of a dip with that. We might see a little bit of a dip with the, as the baby's coming down, if we have a short cord, to where the cord is being compressed by being pulled tight. So we might see some variable decelerations with that. Remember, fetal circulation is bypassing the lungs. So as our baby is moving out, those lungs are getting compressed and some of that fluid is moving out, which is great once that baby's born. So the baby can take that nice big breath of air, and we have the pressure gradient change, which helps to close off some of those open stents that are allowing for the fetal circulation, and the baby will start to breathe. I am missing a slide. Let me make sure it didn't get transposed. So we're going to talk really quickly about the maternal adaptations. And I will add this slide in to the PowerPoint that you're able to open up so that you can be looking at it when I'm talking to you. However, it's not going to be on your screen right now. I apologize. I don't know where it went. So some of the maternal adaptations that we're looking at, we'll talk about cardiovascular first. So with cardiovascular adaptations, during the second stage of labor, which is the pushing stage, we're going to have an increase in heart rate, which makes sense. Mom's working really hard. Her heart rate's going to go up. We might also see her blood pressure go up. These would be all normal adaptations. We are going to want to watch that blood pressure really closely, though, for moms who already have a little bit of hypertension, because we don't want it to go too high. The blood pressure that goes too high could cause some sort of cerebral vascular accident or other complications. From a respiratory perspective, mom's going to increase her O2 consumption. Some moms end up hyperventilating because they're trying to breathe through the intensity of labor. And this is just labor in general, not just the second stage. So some things that we can do for our moms, a nice nursing intervention. If we notice a mom is hyperventilating, remember the drive to breathe is based off of CO2 buildup, not O2 deprivation. So we want to decrease her rate of breathing if she's hyperventilating. Since we don't have paper bags readily available to us in the labor room, a great tool is a non-rebreather. So we can put a non-rebreather mask on mom without oxygen flow and let her breathe into that. And that's going to help to slow down her breathing so she can catch her breath, because she's going to be breathing in that CO2 that she's exhaling. Once her breathing has calmed down, then we can provide her with some O2 so that we're able to support her breathing. From a renal perspective, we're going to want to keep the bladder empty. So for our epiduralized patients, we're going to put a Foley in, and that's going to stay in until they push. And then depending on how long they push, we might straight cath them afterwards, or we might just get them up to go to the bathroom after they've recovered and are not numb anymore. So it's just going to depend on how long they push. For our non-epiduralized patients, we're going to want to encourage frequent voiding. We're going to be providing them fluids, both intravenous and oral, so we want to make sure that they are voiding frequently. It is thought that a full bladder could prevent the adequate descent of the fetus, so we definitely want to keep that bladder empty. The integumentary system is going to experience a lot of stretching, especially the pelvic floor. The muscles and the skin of the perineum is at the least going to experience significant stretching and potentially some tearing. The musculoskeletal system is going to be under extreme stress for the majority of labor. So mom's going to end up having some joint pain and some backaches. And so that postpartum ibuprofen is really going to help her get through her musculoskeletal adaptations, in addition to the pain of being in a postpartum state. Neurologically, we're going to see an increase in endorphins, especially as the second stage of labor sets in, which is great because mom needs that energy and that drive to really push that baby out. Also, with Ferguson's reflux, we're going to see a decrease in pain with the release of the oxytocin and the endorphins. And a lot of women will report feeling much better when they're pushing. And you'll notice that a woman goes from seeming almost squirmy through contractions to when she's pushing to really focused and able to just utilize that discomfort and that intensity to push the baby out. And that's in part due to the endorphins that are being released. From an immunological perspective, white blood cells increase. So we might see a white blood cell count of up to 25,000 when a mom is in labor. GI, we're going to see an increase in nausea and vomiting. I always joke that labor and delivery is the place where we love it when our patients puke. We love it when they have bleeding, and we love it when they're in pain because it means that they're progressing. So it's true, though. Nausea and vomiting shows that the mom is progressing in labor. Also, the change in thoracic pressure when the vomiting occurs really helps mom push the baby out. So it ends up working in her favor, although it's incredibly unpleasant. From an endocrine system perspective, labor starts, and we don't have this down to a science. Trust me, we wish we did. But some of the changes that occur is that we see a decrease in progesterone and an increase in estrogen, oxytocin, and prostaglandins in a laboring mother. So when we're discussing pain in labor, it's coming from a variety of different places. So it's neurologic in origin. And earlier in labor, we're going to have visceral pain. So this is pain that's coming from the organs. We have the cervix, which is opening up and thinning out. We have significant pressure in the lower uterine segments that's pulling the lower uterine segment up, and then the pressure of the baby moving down. Later in labor, we move into more of a somatic pain, which is deep, intense, and sharp. And this is the opening of the pelvis and the stretching of the tissues. It's almost the literally splitting open the pelvis for the baby to fit through. Some people end up with a separated pubic bone, which is excruciating for long periods of time after birth. And this is the pain that's felt from the somatic system. So what are we seeing when we're looking at our pain? So our moms are going to be verbalizing that they have pain, and we're going to see some physiological changes as well. We'll see an increase in their vital signs. So if we have a mom come in very active labor whose blood pressure is, let's say, 145 or even 150 over 85, we're not necessarily going to work her up for preeclampsia or pregnancy-induced hypertension until we get her pain under control. If we get her pain under control and her blood pressure is still elevated, then we're going to look at those other causes of the elevated blood pressure. But initially, if she's in pain, we're going to try to get that under control for her first. So we see an increase in vital signs. We see the hyperventilation, which we talked about earlier. Nausea and vomiting is very common when pain response is that gastric acidity increases. So when that happens, you get nauseous and some vomiting. Some things that are going to have an impact on how the pain is perceived and how the pain is felt is going to be fatigue, which could accompany birth complications. So if a mom has been in labor for a long period of time, it's going to be more challenging for her to cope with the intensity of the contractions than somebody who's only been coping for, let's say, 2 hours. So somebody who's been coping for a long time is going to have a more difficult time to continue coping because she becomes tired and exhausted. From a cultural perspective, every culture approaches pain differently. There's also some specific cultural beliefs surrounding labor and how pain should be managed in labor. In the Hispanic culture, many women believe that the epidural is going to cause major back problems, and so they don't want to get the epidural. In addition, the older women in the culture don't believe that she should get the epidural. They believe she should experience what's going on. So sometimes you have the mom in the room who's telling our patient that she can't get the epidural, and we have the patient asking for the epidural. And we have to gently let the mother know that this is not her decision, it's the patient's decision, and we are going to do what the patient wishes. And sometimes we end up with patients who follow mom's advice even though they really don't want to. And you can see on their face how much they really want to be done and they don't want to let down mom. So it's just something to consider and take into perspective when we are helping our patients cope with the discomfort of labor. Anxiety is going to increase the pain perceived. A previous experience is going to have a definite impact on the current experience. If the previous experience was horrible, there's going to be less coping that the woman's able to do because she's coming from the perspective of the previous experience. The gate control theory of pain is very interesting, and we're going to actually discuss this more in class. So what are some non-pharmacological things that we can do for these moms? So effleurage and counterpressure are great, and these are things that I put dad to work doing. So if dad's standing there or significant other is standing there and not doing anything, I have them come over, and effleurage is a very light, gentle touch. It's kind of stroking with fingertips is essentially what it is. And it always makes me giggle to myself when I tell a dad to do that because inevitably they go really fast. And that's not helping. So we want to go really slow, just slowly up and down the arm or the legs. And that just helps the mom to refocus her feeling. So she's able to focus on that, which is a nice pleasant feeling, rather than the intensity of the contractions. Counter pressure is really useful for those occiput posterior babies or big babies. When mom's having a lot of back labor, if we can provide counter pressure on the sacrum, it feels so good. It's so nice to have that counter pressure. And everything we do, we're going to want to check in with mom and make sure it's helping and not making things worse. Some moms really like to focus on music, so they'll have a playlist that they put together prior to their birth, and we'll be able to focus on specific music. Being in a tub is kind of comforting. It takes a lot of the pressure off, so some of the musculoskeletal stress that is occurring in labor is relieved. Labor has been equated to running 2 back-to-back marathons. So that's the amount of stress the woman's body is put through when she is going through labor. And breathing techniques. Being able to focus on breathing is really helpful and making sure that mom's getting adequate oxygen. When a muscle is in pain, so when pain is muscular, what we are feeling there is the lack of oxygen flowing to the muscle. And that is one of the causes of the pain. So if we can have mom breathe adequately, then she's going to have a much easier time controlling her pain. And once mom's done with the non-pharmacological pain control, or if she decides early on that that's not for her, that's okay. We have lots of different options. We can use a systemic analgesia, which we usually use a morphine derivative. Fentanyl is the most commonly used analgesia right now for active labor. In early labor, we will use morphine, but the half-life of morphine is about 4 hours. And so we would be concerned that the baby would be born with some morphine on board, which we don't want, because then they're not going to want to breathe adequately. So the fentanyl is much faster acting. The half-life of fentanyl, I believe, is 30 minutes. So it's not going to provide long-term pain relief, but it might provide her enough of a relief to get her through. She might just need a little break. So fentanyl is a great option. And then we have the nerve block. So this is our epidural. And we'll get a little bit more specific on that in a few minutes. And then general anesthesia. And general anesthesia is used in the OR sometimes when mom doesn't have adequate pain control from her epidural, which we then dose as a spinal. So the medication for the epidural is different than the medication we utilize if we're going to be doing a cesarean section. And sometimes mom doesn't get adequate pain control, so then she's put under general anesthesia. The other reason she would be put under general anesthesia is if she was what we call a crash C-section. So if there was an emergency and she did not have an epidural already, then we would need to put her under general because we wouldn't have time to place the epidural before delivering the baby to help make sure that we have both a healthy mom and baby. So the mom would go under general. There's a few other specific instances, such as women who have like a full spinal fusion. They're not going to be able to get into their epidural space, so they would probably go under general, or they'd have to go under general for surgery or choose a natural childbirth vaginally. So with the epidural, you can see that the needle is inserted into the epidural space. And what happens is that the nerves are then bathed in the medicine and it provides complete pain relief. So most women will have complete relief from pain with an epidural. And here's another picture. And this is great because it shows you the difference between the epidural and the spinal. So the epidural is lower, typically, than the spinal block, and it covers more space. So for a vaginal birth, our goal is to stop the pain in the uterus, and typically the legs are numb, but the belly is not. Because if you look at this picture, those nerves that innervate the uterus are in this area here. But if we could see all of the nerves that are innervating the skin, they would be further up. So we're going to numb the uterus, but the skin isn't necessarily going to be numb. Mom's legs, on the other hand, are going to be numb. With a spinal, we obviously want the skin to be numb because the incision is going to be right about here. So for the cesarean. a few more things on this. With an epidural, keep in mind that the epidural can cause a systemic vasodilation, and the spinal can as well. And so if that occurs, we're going to have a decrease in maternal blood pressure, and we're going to see that reflected in the baby's heart rate as well. So we want to make sure that we're taking frequent blood pressures after that we've given mom a fluid bolus, and we might need to give her some ephedrine, which is a vasoconstrictor, to bring her blood pressure back up. If we're seeing the baby, if we're seeing the effects of the epidural on the baby, for instance, we see late decelerations because mom's blood pressure went down, then we're going to want to treat mom with the ephedrine. Otherwise, we can, if it's just mom's blood pressure, then we can utilize techniques such as a fluid bolus and laying her down and turning her to her side. So moving on to fetal assessment. And some of this information is a repeat from our OB survival skills, but we are going to go over it again. So how is the fetus responding to labor? Remember that when the contraction occurs, the blood flow to the fetus and therefore the oxygenation is decreased. Now, most healthy babies are going to be able to cope with this just fine. Their systems are designed for this. There might be situations where either the baby's not healthy or mom has something called a tetanic contraction, to where the contraction lasts longer than 2 minutes, or mom has what we call tachysystole, so that's more than 5 contractions in 10 minutes. So she's not getting that 1 minute rest period, and the baby's not getting that 1 minute rest period from a contraction to be able to reoxygenate. In that case, we're going to have to intervene. So when we look at fetal well-being and we're assessing the fetal strip, we're looking for a heart rate with a baseline of 110 to 160, moderate variability. We don't want to see any late and few variables, and we're happy if we see accels and early decels are okay. So a category 1 strip, which is our common terminology, indicates exactly this: baseline of 110 to 160, moderate variability, no variables or lates, and accels or earlies are okay. So we have a couple different ways that we can monitor. We can monitor using the intermittent auscultation, in which case we would listen periodically to the heart rate. The standard is 40 minutes off the monitor and 20 minutes on. And when we say auscultation, we're actually referring to more of a Doppler ultrasound, and this would be more of a birth center or home birth intervention, to where they listen every 30 minutes through one contraction. And what they're listening for is the decel after the contraction, or the variable during the contraction. So they're listening for those signs that maybe this baby isn't coping fabulous with this. The NICHD definitions were put into place to try to help nurses and providers have common terminology that is defined and has meaning. So for instance, I mentioned category 1 on the last slide. So we have 3 categories: category 1, category 2, category 3. Category 1, I described on the last slide. Category 3 would be a strip that has minimal or absent variability with recurrent late decelerations, or a sinusodal strip. And both of those are indicative of a compromised baby, in which case we want to move to delivery, and the goal is delivery within 30 minutes. So that's category 3. Category 1 is a perfectly happy baby, and category 2 is everything in the middle. So the goal of this terminology again was to have a standardized communication that the providers and the nurses could utilize. So instead of me as the nurse calling the provider and saying, hey, I need an order for Pitocin, she's not changing her cervix, baby looks good, or I need to turn off my Pitocin, my baby looks crappy. Those are not standardized terms. What's good to me and what's crappy to me might not follow the same lines of what's good and crappy to somebody else. So utilizing the categories gives us that standardized language. EFM is going to be external fetal monitoring, and that's going to be our ultrasound and our TOCO, which go on the mom's tummy. And then the internal monitoring is the FSE, the fetal scalp electrode, and the IUPC, the intrauterine pressure catheter. So here's some of the auscultation tools. This is a Doppler. This is a Doppler stethoscope, and this is a fetoscope. And for this one, you put obviously these go in your ears, this goes on your forehead, and this goes on mom's abdomen. And we're able to listen to the heart rate. So we actually have one of these for every room in case we have power outage and we're not able to assess babies with other means. And it's more of a long-term. We also have a couple Dopplers. Every hospital has a couple handheld Dopplers, but this is a safety thing that the Joint Commission has decided that we need to have a fetoscope available for every patient. So here's an example of our external monitoring. And as you can see, they're monitors that go on mom's belly and get strapped on. And the TOCO, which is for uterine contractions, is going to be at the top, the fundus, because that's the part of the uterus that we're going to be able to assess what's going on with the contractions. And the fetal heart ultrasound transducer is further down, and it's usually to one side or the other because we're getting it off the fetal back is what we're pulling the heart rate off of. So when mom is turned, so you can see she has a slight tilt. She's actually slightly tilted to the left. So I would have expected to find the heart rate on the right. So whichever way mom's tilted, we're going to usually find the heart rate on the upside because baby's going to flip to that side. And here's a picture of our internal monitors. So we have our intrauterine pressure catheter, which goes up into the space with the baby, into the uterus, and it has a little transducer at the end that gives us the actual pressure that's occurring in millimeters of mercury. And then we have the fetal scalp electrode, which is a little electrode that we attach to the baby's head. So when we're looking at the fetal strip, we're looking for baseline heart rate. We're looking to determine from the baseline whether there's any tachycardia, so above 160, or bradycardia, so below 110. And we're assessing the variability. So variability can be absent, minimal, moderate, or marked. We can also have a sinusodal strip, which I'll show you an example of later, but it's essentially just looks sinusodal, and we cannot determine a baseline off a sinusodal strip. And sinusodal is an indication of fetal anemia, and it's a true emergency. We should be delivering that baby pretty rapidly after identifying the sinusodal. With absent variability, absent looks like a straight line, and sometimes you'll hear the term pancake. Minimal variability is between 1 and 5 variability, beat to beat variability. Moderate is 6 to 25, and marked is 25 or above. We'll get some pictures here. So here is an example of fetal tachycardia. And now this would be minimal variability because you can see there's a little bit of change here and there, okay? It's not a flat line, but it's definitely not moderate, and it's close to absent, but it is minimal because of these little blips. This is also minimal, and this is bradycardia, so we're down below the 110 range. This is a baseline of 100. So here's some great examples of variability. So here's our absent variability. So you can see it looks like a straight line, and there's essentially no beat-to-beat variability. There's little here, but it's not enough to constitute variability. Here we have minimal variability because we do have a few more little blips here and there. Here's our moderate variability. So you can see that the beat-to-beat variation is at least 6 beats difference. So from here to here is 10, because remember, each of these little blocks is 10 up and 10 across. And here's our moderate variability. So we're okay with minimal variability for short periods of time. Most likely that's just the baby's sleep cycle. We really love moderate variability. The single best indicator of fetal oxygenation is variability. So if we have moderate variability, we know our baby is well oxygenated. I'm going to say that again. The single best indicator of fetal oxygenation is variability. So if we have moderate variability, we know we have a well oxygenated baby. Marked variability for a short period of time is okay. It might be fetal excitability. However, if we see marked variability for more than 20 minutes, we are going to start to do some interventions because it's probably a sign that that baby is in some sort of duress. Absent variability is always ominous. So I mentioned the sinusoidal. So here again is here is an example of a sinusoidal fetal heart rate pattern. You can see how we can't establish any sort of baseline, right? We can go right in the middle of it, but that's not that's not an actual baseline. So this again is an indication of fetal anemia, and we're going to want to deliver this kid as quickly as possible. So moving on to our periodic versus our episodic changes. So I don't know about you, but I cannot remember what periodic versus episodic means. But the way I remember it, which might be useful to you, is that I know that the symbol, the P with a line on top of it, means with, and periodic means with. So I just think about the P with the line means with. So our periodic changes are going to occur with contractions, and our episodic changes are going to occur independent of contractions. Now, truthfully, all of these could occur with contractions. Lates and earlies have to be periodic only. They are not episodic because they are based off of the contraction itself. So we don't know if we're having a late or an early decel without being able to see when the contraction's occurring. So a late and an early are always going to be periodic changes. We could have an episodic variable, episodic acceleration, or episodic prolonged deceleration as well. But those could all be periodic as well, again, due to the contraction. So late and early must be periodic, and everything else can be periodic or episodic. Accelerations we like, decelerations for the most part we don't. You can see the smiley face compared to the sad face. So earlies show us that the baby is coming down. It's due to fetal head compression, so that's a good sign, and it doesn't show any indication of fetal compromise. Lates we don't like variables, every once in a while, a variable's okay, but recurrent variables are going to are going to end up compromising that kiddo. And we don't like prolonged decels either. So here's an example of an acceleration. So any baby over 32 weeks should be able to produce a 15 by 15 acceleration. And from a charting perspective, we do not chart that it's an acceleration unless they had two within the 30 minutes and they're both 15 by 15. Babies under 32 weeks can produce a 10 by 10 acceleration. And that has to do with their neurological development. So under 32 weeks, we only expect a 10 by 10, which means that the acceleration goes 10 beats above baseline and lasts for at least 10 seconds. And for 32 weeks or above, so 32 through term, which most of our patients laboring are term, so between 37 and 42 weeks, then we will expect that baby to be able to produce a 15 by 15 acceleration. So it goes 15 beats above baseline and lasts for at least 15 seconds. So here our baseline's 130, and this accel goes up to 145. And it's lasting, so here's probably 5 seconds, here's 10, so it's lasting 20 seconds. So this is a qualifying acceleration, as is this, because it goes up to 145 from 130, so we go up 15, and we're lasting for 15 seconds. Decelerations, when we're looking at excuse me, early decelerations, you can see that our contractions and our decels line up. And this again is due to the head compression. It's the vagal response of the baby. So the head gets compressed and the blood pressure goes down, so the heart rate goes down, and then it comes back up and recovers before the end of the contraction. You can see the onsets at the beginning of the contraction and the recoveries by the end of the contraction. We have good variability in between. Late decelerations are due to uteroplacental insufficiency, and late has a late onset, typically about halfway through the contraction, and it takes a little bit for them to recover, so a late recovery. So they have a late onset and late recovery. So you can see how important it is to be able to truly see what our contractions are doing so that we can adequately assess what our fetal heart rate is doing. Variables are typically due to fetal cord compression, the umbilical cord compression, and we're going to see them like a V shape because, again, from the physiology standpoint of it, the cord's going to be compressed quickly, which is going to rapidly drop the baby's blood pressure. So we might see what's called a shoulder, where we're going to see a little bit of an increase in the heart rate beforehand, and that's the baby trying to compensate for the decrease in blood pressure. But the baby can only sustain that for so long, so then we're going to see a rapid drop in, the heart rate, in which case the baby says, I don't like that, and the baby's going to move a little bit, or if it's due to the contraction, when the contraction lets up, then the baby's able to recover quickly. So if we see it in relation to our contractions, then we're going to assume that there's a cord somewhere. If we see it just episodically throughout, just randomly not associated with a contraction. So if we see an episodic variable, then it's probably just that the baby got tangled up in its cord or grabbed its cord or was in a funky position for a minute. So moving mom is really going to help with this variable decels. And then here we have an example of some late prolonged decels. And these are prolonged because they last more than 2 minutes. So you can see the onset of this deceleration is right here. And we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. 18, 19, 20, 21, 22, it kind of recovers and then just goes right back down. So technically this decel goes from this point here all the way to over here. So it's, let's see here. That's about a half a minute. So 1, 2, 3, 4, 5, 6.5 minutes. So that's a long decel. And we do not assess variability during a decel at all. So this does not indicate fetal well-being because it looks like the baby has variability. Variability is a aspect of the baseline, not an aspect of a deceleration. So what are we going to do if we're having some decelerations? We're going to change mom's position. This is especially important during variable decels and prolonged decels. We're going to be flipping mom back and forth, just back and forth, back and forth, back and forth during prolonged decelerations. We're going to give her an IV fluid bolus. We're going to put some oxygen on her in a simple mask at simple or a partial non-rebreather, whatever's available to you, at 10 liters per minute. We're going to do an SVE, which is a sterile vaginal exam. And we're doing that to make sure that there's no cord, that there's not a prolapsed umbilical cord. We also want to know if the baby came down quickly. So maybe the baby was at a -3 station and now the baby's +2. That's going to cause significant stress on the baby, and it's just going to take some time for that baby to recover. But that's okay. The baby will recover. It's just going to take a little bit of time. So if we know that, then we're not going to run for a C-section. We're going to turn off our Pitocin because we want to provide this baby with as much oxygenation as possible. We're going to notify our provider. We might give some terbutaline if we've got that tetanic contraction or tachysystole situation. So remember, that's when the contraction is lasting for more than 2 minutes, or we're having more than 5 contractions in a 10-minute period of time. So anytime we're not giving that baby the 60 seconds to recover, then we might want to consider giving some terbutaline, which will relax the uterus immediately. And then we're going to need to educate mom, though, because terbutaline is going to cause a rapid increase in her heart rate. We might want to put on some internal monitors if we're having a difficult time assessing the fetal heart rate. And we're going to try to deliver the baby, so sterile vaginal delivery or a C-section if we're not able to bring the baby's heart rate up. So this is actually a good list, and it's in the order that we should do them in. So we want to do our least invasive procedures first, right? Honestly, we're going to be doing the position change, the IV bolus, and the oxygen all at once. So I'm going to be flipping the baby or flipping the mom. My friend who came to help me is going to be opening the LR wide open and putting oxygen on mom. So we don't flip mom and wait to see what happens. We do those 3 somewhat simultaneously. There are our good arsenal for fetal resuscitation, intrauterine resuscitation. And if those don't work, then we'll start to move to other things. So another way we can assess the fetal well-being is we could do some fetal scalp stimulation, to where we do a sterile vaginal examination and we rub the baby's head. If the baby has a acceleration associated with that, then baby's doing okay. If baby has a deceleration associated with that, baby's not doing good at all. And if baby does nothing, then we're going to be a little bit concerned as well. After the baby is born, we can send for the cord gases to determine what the blood gas numbers were to see if this baby was in an acidotic state. This is done for a couple different reasons. If the baby was severely acidotic at birth, the baby will go to the NICU and will be put on cooling blankets. They're usually cooled for 72 hours, and the NICU brings them down to a hypothermic state which slows the brain activity and decreases the risk of seizures, which is a result of the acidotic state, which decreases the risk of brain damage. We've had significant positive outcomes utilizing cooling measures in acidotic newborns. So other things that we can do would be an amnio infusion. So if we are seeing those recurrent variable decelerations, we might want to give mom a little bit of more fluid in the uterus. And we can do that through the intrauterine pressure catheter if it's placed. We can infuse some normal saline into the uterus to give a little bit more cushion and space. And the tocolysis is utilized, that's the terbutaline, to help stop the contractions. So what is some of our nursing care that we're going to do for our moms who are in the intrapartum state? So first, when mom comes in, we need to determine, is she in labor? So we're going to take a look at the baby on the monitor. We're going to take a look at her contraction pattern, and we're going to do a SVE. And we're going to gather all this information that's listed here. So we want to know her prenatal information. Specifically, we want to know her labs. We want to know her blood type. If she's Rh negative, we want to know if she got RhoGAM. We want to know her GBS status. So is she positive or negative, which is going to indicate whether we need to give her antibiotics during labor. And we want to know how many babies she's had. We want to know how many weeks she is. So that's all going to be found in the prenatal information. We're going to assess for rupture of membranes. And the picture that's here is what we look for. So what we do for rupture of membranes is typically we'll do a preliminary test utilizing nitrazine paper. And nitrazine paper is kind of a olive green color. And if we dip it in the fluid that we're seeing and the paper turns yellow, then it's not amniotic fluid. If the paper turns blue, then it could be amniotic fluid. It could also be blood, which when you're in labor, there's definitely blood. So it could be urine if the urine is of the same pH. So it's not a definitive test. So if we suspect rupture of membranes and mom's not sitting in a big puddle of fluid and we're not positive based off of our initial assessment, then we'll do what's called a Fern test, to where we take and do a sterile speculum exam and swab some of the fluid and put it on a slide, and we let it dry. And once we let it dry, it looks like this fern right here. It's kind of pretty, huh? And that allows us to determine, okay, yes, there is amniotic fluid because we saw the ferning. And what it is the crystals that are within the salt within the amniotic fluid forms crystals when it dries. And so that's what we're looking at. We're going to want to know what mom's plan is for her birth. Is she planning an epidural right now? Is she wanting to have a natural childbirth? Does she want her and her 25 closest family members in the room with her, or is it just going to be her and the significant other or spouse? So we want to know a little bit about her plan so that we can discuss what she can and can't do based off of our hospital policies, and so that we can support her in what it is that she wants. Cultural and social factors are going to impact mom's labor and her birth as well. So we want to ask if they have any cultural preferences that they would like us to honor or uphold during their labor and during their hospital stay. From a physical exam standpoint, to determine whether mom's in labor, we need to do a sterile vaginal exam because we need to know what her dilation is. We are considering active labor is 6 centimeters or more. So if mom's not 6 centimeters yet, we might have her walk or we might send her home. Then we're going to look at some labs. We definitely want a urine to determine if there's protein in her urine. And we're going to look back at her prenatal labs to see, again, what her blood type is. We're going to want to know if she's positive for any STDs. We're going to ask her about herpes and see if she has a history of herpes. If so, has she been taking her acyclovir? Has she been does she have a current outbreak? So, and the providers will check for that as well. So here's just an example of some of those cultural aspects that could impact the care that we provide. There's a wide variation of whether laboring moms should eat food. So the Pawnee Indians do not permit laboring women to eat or drink, whereas the African culture wants women to keep drinking some soup to keep them strong during labor. We kind of find a happy medium where most hospital policies is clear liquids. And so they can have Jello and juice and as much water as they want and popsicles to keep them going. And the way I describe it to my patients is I just say, and now that you're here with us, you're on what we lovingly call a clear liquid diet. But trust me, it's for the best because most women end up throwing up through labor. And I don't know about you, but I would much rather throw up clear liquids than a hearty hamburger. And I usually get a little chuckle and they're like, oh yeah, that makes sense. So most women don't want to eat in labor, but for those that do, if you tell them that they're going to be throwing up and wouldn't you rather throw up clear liquids, they usually are perfectly fine with that. So here we have the various stages of labor. So the first stage of labor is from the start of contractions through complete dilation. And we have various stages within the first stage of labor. We have the latent stage, which our patients are going to be walking around. So that's usually from 0 dilation to about 6 being about 6 centimeters, between 4 and 6 centimeters. And these women, if their water's not broken, there's no other risk factors, we're going to send them home because that's the best place for them. They can move, they can walk, we're not assessing their baby all the time, they can eat what they want. Some of these women are in a lot of pain at this time, in which case we would probably give them some morphine. We usually do a shot of morphine, an IM shot of morphine and some IV morphine and send them on their merry way. And that usually takes care of the pain for, again, probably about 4 or 5 hours. The active stage of labor, some of the things we're going to do for our moms is have them walk if they don't have an epidural. We want to make sure that they are maintaining adequate hygiene. So we're going to provide them with peri pads, and we're going to want to be changing their peri pads and keeping them dry. Providing fluids, both oral and IV, lots of position changes. I've mentioned this before, but in the active stage of labor, we should be changing our mom's position about every hour, and pain management, whatever they want. So if they want that epidural, we're going to get them that epidural. If they want to be natural, we're going to support them in however their ideas of natural childbirth are. And providing support. And that's key during the active and transitional stages of labor, is being there and supporting that mom. Transition is essentially going to complete. So 8, 9 centimeters to 10. And it can be incredibly intense. And this is the point where most women throw in the towel and say, I am done. I don't want to do this anymore. Give me the epidural. And usually it's when they're just about done. So we can manage that in a few different ways of checking them and seeing where they are and helping to support them and giving them the support they need to get through that very difficult time because it's incredibly intense. The second stage, we are assisting the mom with pushing. So we are helping to count. We're helping her figure out where to push, how to push, what positions to push in, and preparing for the birth of the baby. The third stage it's after the baby's been born. and before the placenta. So the placenta, we're waiting for the placental separation. We're working in conjunction with our provider to provide the medication to mom that mom might need to help with the placental separation and help with the involution of the uterus. We're going to assess whether she's has a hemorrhage risk. If she does, then we're going to have some additional medications at the bedside. We're going to have Hemabate, which we're not going to give to our asthmatic moms. We're going to have Methergin, which we're not going to give to our hypertensive moms. And we're going to have Cytotec, in addition to the additional Pitocin, which will run after the placenta is born. And the fourth stage is that period of time where the mom and baby are still in labor and delivery, and they're still there because they're at a risk of hemorrhage and decompensation. And so we're doing more frequent assessments and just making sure that mom and baby are both stable. So here's an example of an episiotomy. So here's baby's head crowning, and sometimes most physicians, if they need to cut an episiotomy, and now current practice is not to cut, that cutting an episiotomy automatically gives you a second degree because you're cutting through not only the superficial tissue, but also the muscle of the perineum. So where if mom's just allowed to tear, typically she'll just have a first degree to where it's just the superficial tissues. But there are some medical indications for an episiotomy. So if it does need to be cut, they'll typically do a medial lateral. And the reason why is because you can see this median or midline. Where does that go directly to? Directly to the rectum. And if they start the cut and the baby is just pushing and pushing, it might extend through the rectum, which is considered a fourth degree, which we never ever want. They're horrendous, and these poor moms have such a tough time afterwards. In fact, any mom who has a fourth degree is offered a C-section for her second kid or subsequent children, just because it is, it's so hard on them. And on a happy note, episiotomies, woohoo! So that is it for our intrapartum lecture, and I will be putting the intrapartum complication lecture up next. Please be sure to bring in any questions that you have. We'll discuss them in class first thing, or you can always shoot me an email with whatever questions you have. Have a great day.